Welcome back, everybody, to another episode of the Rated RX podcast. I'm Robbie Abasi here with Xavier Hill, Sam Lona, and we have a special guest joining us today, Hila, who is a pharmacy student in University of Toronto in Canada. Hila, please tell us a little bit about yourself.
Hi, everyone. My name is Hila. Thank you so much for having me here today. I'm very excited to bring the student perspective. I'm currently a fourth-year student completing my API rotations. Currently doing my rotations, and I'm a student at University of Toronto, and it is also a 4-year program here. But starting this year, it's becoming a 3-year program at my university. Some changes happening a little bit on the side of the border.
And is that year-round? So you're going to year-round 3-year?
Yeah, so it's going to be no summer breaks for these incoming student cohort. Yeah.
Okay.
Yeah.
How do you feel about that?
I think it's nice because these students can enter their profession a bit faster, accelerated. Our last year is no more, it's not academic anymore. We're not learning anything. It's just placements. But I do think that 1 year of placements is great of trying different things out. I think burnout will be a problem. I'm concerned about that. I myself experienced a lot of burnout with my classmates. We didn't get a fall reading week in first year. And after they kind of got some feedback, students were really struggling. After that, they implemented a fall reading week. So I cannot imagine what it will be like nonstop 3 years back to back with, I believe it's going to be an implemented mandatory 1 day a week rotation.
Okay.
I don't know how it's going to help with learning. When we do month-long placements, you learn a lot coming to work every day. If you're going to work only once a week, could be hard. You're not going to come across a lot of different scenarios, but they get more consistent exposure throughout the year. So
We do have a couple schools that are accelerated 3-year programs, or accelerated 4-year programs here in the U.S. where they go to school year round. So we do have that here, and some people probably can relate to what they're going through. There have been some successful schools that implemented those changes, so it could work out.
yeah, and I do want to clarify, it's just University of Toronto starting that 3-year program. Some of the other pharmacy schools in Ontario are still 4 years.
Yeah, well, tell us a little bit about the pharmacy structure over there in Toronto, what it takes to go to pharmacy school, graduate. Here in the U.S., it's at minimum 2 years of prerequisites, and then depending on where you go to school, it might be 3 years, 4 years. How is it structured over in Canada? And I'll say it correctly this time.
Yeah, absolutely. So I believe they actually changed our curriculum to make it very similar to the US curriculum. So now it's a PharmD as well, and it's the exact same pattern. So you have to do mandatory 2 years of undergrad, could be in any program. There were some mandatory course requirements, and different schools have different requirements. Some schools require you to write the PCAT. Others don't. And then it's GPA based as well. I actually don't recall exactly. It's a higher GPA. I think it's like a 3.5 or more. I think that minimum is like 3.2, but the typical average of getting in is about 3.6, 3.8 to get accepted. I think about 1,000 students or more apply every year. And my class is about 250 students. Yeah.
Hey, wow.
Yeah.
Good size. What about moving back and forth? Are you guys considering working there? I know you're close to the U.S. there, coming down here and life here, or the other way around. Heard of people from here moving up to Toronto or other areas there?
Absolutely. I myself have considered it for sure, working in the US. A lot of my friends and I, we talk about this all the time. I think there's certain aspects of a pharmacy here that I do like. I do like that now we're allowed to prescribe for minor ailments, at least in Ontario. Currently, we're allowed to prescribe for 19 minor ailments. And this was updated recently from, I think we started with 13, now it's 19. few more are actually coming as well. So I feel like we're getting more of a clinical role now. We're really even in community, we're really getting introduced as a clinical pharmacist in all kind of areas. So I know myself, like I can't see myself just dispensing 24/7. I don't want to just check. I want to be able to kind of like have that clinical aspect. But in terms of salary, based on just research, it's very clear that US pharmacists make a lot more. And that's something that a lot of us, we joke about. We're like, oh, it would be nice to go there, have a nice salary. The housing market in Canada, I don't know if you guys have heard, it's tough.
Oh, okay.
So a lot of yeah, so we're very about, can we survive off of essentially our salary? I think in the main city, the starting salary of a newly graduated pharmacist is about starting 48 an hour in Canadian dollars. And we pay a lot in taxes. So it's things we keep in mind. If you go out of the city, you go more up north, you can definitely go in areas where you can make $75 an hour, but those are very rural areas. So I'm sure it's a bit similar there. But yeah, so I believe just overall in the US, pharmacists are known to have higher income than in Canada.
What's the average cost of pharmacy school in Canada?
So I would say about 18 to 20 a year.
Okay.
Maybe a little bit more depending on some of the schools. Yeah, so for us, I think it adds up to being about 20 per year. And on my final year, because of my API rotations, also including the summer, it's a bit more. It's almost like 25.
Mhm.
Yeah.
Wow.
Yeah, it's expensive.
Yeah, it adds up.
It really does.
Any other questions for Hila before we get started?
Yeah.
I'm sure we'll have more along the way. Let's just kick off the fun.
Yeah, let's get started. Okay, Sam, please take it away for our next segment.
All right, we got the Plan B blind draft. So, Hila, we're going to have a subject here and then 5 different options. I'm going to say one of them, and you have to blindly put them in order without knowing what's going to come up. Number 1 will be, in this case, most wanted or hated. So the topic will be things I'm glad are over from pharmacy school. So number 1 will be most glad. Number 5 will be least glad or least caring that you don't have to deal with it.
Yeah.
And you guys will discuss a little bit and then have to pick one together. And then we'll move on to the next one, get through all 5 and see how we feel we ranked them.
In the past, we've usually let the guest lead the charge here. So we're going to let you rank it. We'll try to sway you one way or the other, but you are the final decider, okay? This is all on your shoulders, okay? This is a test prep for you being in charge when you graduate.
Wow. Lots of pressure here.
No pressure, no pressure.
All right, so the first one, things I'm glad are over from pharmacy school. First, soap notes that took 3 hours, and I got a 72%. Those dang soap notes.
Those are terrible. Those are terrible. I remember they wanted you to do it in a particular way, and if you didn't do it in the right order, you got dock points.
Wait, how much time did you say? 3 hours?
3 hours, just soap notes that took you forever. You didn't end up getting a good grade. Very particular, losing minor points. Just soap notes you got to do in general. How glad potentially you're not having to do a bunch of soap notes.
I feel like there's worse, so I'm going to put this at 4.
4, okay, so not too bad. We're not too
bad.
worried about it.
Yeah.
Okay.
I feel okay with that. And like those are definitely annoying in pharmacy school. Glad when you practice more and get more experience, you can do them a little bit faster and in your mind. But back then, yeah, I was glad to be done with it for sure.
I think some providers should learn how to do some soap notes again.
Lock it in at 4. So next one, memorizing drug mechanisms you'll never see in real life.
Oh my God. So you're bringing back trauma from molecular pharmacology. First, oh my
Trauma's
God.
coming.
I'm going to rank that at 2.
2. So, okay,
Wow.
some real
That bad.
some real trauma there.
I'll admit I actually like pharmacology a little bit. Once you understand the general patterns of the receptors, it's kind of fun because you can kind of predict what's going to happen. But It's a weird kind of torture to enjoy.
Okay.
I'll put it at 2.
Yeah, I feel like I learned more about physiology from pharmacology than I did in my actual physio class.
I agree. Yeah.
Learn those
Pharmacology
connections.
was fun for sure.
All right, so we locked in at 2. Next one is learning an entire disease state in one lecture. You got 80 slides, 50 minutes. Here we go.
Those are the worst. That's a tough, but
You
I
gotta
don't
know it, but you gotta know it. Doesn't
Dang.
go away when you graduate.
I'll put this. We have up to 5, right? Okay.
gonna be 5
I'm
of
gonna
them.
give this one a 3.
A 3. Okay, right in the middle.
Okay. Now we
Right
got
in the middle.
the,
What do you guys think of that?
I don't know. Sam tends to put the bad stuff towards the end.
Yeah. I mean, he might throw a curveball here. Who knows?
We'll see. We'll see.
Okay. So we got 1 and 5 left. Next one is waiting for exam grades like it was a medical diagnosis.
I'm gonna put that in 1.
I
That was
hated that.
the worst.
Especially when you're out of your exam, that's when you learn the most information. Like, what did you put? Oh, I put this. Like, oh no, I got that wrong. Oh, it's because of this. It's like, no. That's like when you learn the most info, you know?
We have a friend when we come. I'm the person that likes to debrief. I need to know if I failed or passed.
What did you
But
put?
we have a friend that she hates it. She will literally plug her ears and just be like, "Don't talk."
What's done is done.
She is checked out.
It's like
I'm
done.
gonna put
It's
that
over.
as 1.
Number 1. Okay.
Yeah.
Number
There's
1.
there's this like I can't even describe that anxiety when you're waiting for marks to be released, especially finals. Like when you want to know if you passed, there's that one course you wrote that exam, you were so certain you failed. Like it's just
Don't miss
putting
it.
that at 1.
Keep refreshing over and over, waiting, building. Okay,
1.
number 1, locked in. That leaves you number 5, which is the constant humiliation of Jeopardy-style review games.
Oh, it's not so bad.
That's a good
Yeah,
5.
I think you did a great job.
All right, so we went with number 1, waiting for exam grades like it was a medical diagnosis. 2, memorizing drug mechanisms you've never seen in real life. 3, learning entire disease states in one lecture. 4, soap notes that took 3 hours and you got a 72. And then 5, the constant humiliation of Jeopardy-style review games.
Hey,
How do you think we did?
Perfect. Yeah.
I think that's
You-
solid.
Spot on the first try.
Okay, easy peasy.
Nice job.
All right.
Way to go, guys.
There's still time for more trauma, don't worry.
That's right.
I think the worst that I know is coming is when I have to write my licensing exam.
Well, you have to write your licensing exam? What is
Yes.
it?
Yes.
Or I guess multiple choice. Yeah, well, the multiple choice or the licensing exam that we have to.
Gotcha. Okay. I was like,
Yeah.
dang, you guys, you Canadians are rough.
No. I believe it's on the computer, but I'm not. Oh my God, waiting to find out if we pass. That's a next year problem. It's a year from now problem.
Worry about right now.
We're about this anxiety, not that anxiety. Be good.
So Robbie and I both did international rotations as P4 students our 4th year. And I actually went to the UK. And then Robbie, where'd you go?
I went to the Philippines.
To the Philippines. But in the
Wow.
UK, they did have to write a lot more than what we did for they call it revisions. I guess it was just notes or study notes or something, but they did have to write a lot more. Is it similar in Canada?
Like studying wise,
Yes.
it's hard for me to compare in terms of lecture content. But there's differences in our guidelines versus American guidelines. I know that for sure. And actually, we sometimes go over both of them. So I know maybe I can't say that for sure. I've watched some TikToks of some pharmacy students in the US and they're like, "Are you smarter than a 3rd-year pharmacy student?" And some of the questions we don't know. I'm like, okay, maybe you guys study more. It's hard to say. We really do emphasize labs, like OSCE style labs, at least my school. I know some schools are different. For example, there's University of Waterloo Pharmacy. They have a wonderful co-op program for their students. So their students are really good, I've heard, at like being prepared for interviews because they have to interview for their co-op placements as pharmacy students. They become really, really good at interviews and things like that. I've heard that University of Toronto is very like academically grilling. Our content is like it's very tough. We have some courses. There's one very well-known course called Molecular Pharmacology in first year that it's so historic that pharmacists from years ago had the same professor, and they're like, if you pass that, you're good. That's the rite of passage.
Sounds like Dr. Roche.
Right?
Yeah, there you go.
The
Everyone
barrier.
has that one. Yeah, so I know University of Toronto is known to be very academically intensive, just like our university is kind of known for that. And they prepare us very like strongly for OSCE style. We have OSCE style labs. So even University of Waterloo students tell us that they feel that U of T students are more prepared for OSCEs. So it kind of depends on the university
go.
and what their main objective is.
Gotcha.
Fun fact, University of Toronto did discover insulin. So we
Cool.
did discover insulin, so we take some pride in
Nice.
academics and we have very research heavy professors. They really like emphasize like new updated guidelines, new studies, and we honestly truly get some wonderful professors. So I think at least my program academically, it's quite heavy. Can't compare to US. I don't know like how different schools are there, but at least within Canada, there's differences between them in that sense.
I'll think you're at a good school.
Yeah. Good choice.
Challenging.
Seems that way. All right, well, let us pass this on to Xavier for the pharmacy fantasy he's got going on. What do you got for us today?
What's up, guys? I have something fun for you guys today. So have you guys watched Harry Potter?
Definitely. Wife is obsessed.
The wife, sure.
Today, we are going to go over the 4 houses of pharmacy, and then we're going to select Hila and put her into a house.
Oh.
I like it.
Wow. Where's the sorting hat?
I know, we need a sorting hat and a sorting pill.
I just realized pharmacists were kind of like the potion masters, if you think of it.
We were.
Snape's our favorite professor, apparently.
These are the 4 house names and a little bit about each house. Capsula is the first house. These are the calculated ones. They are the masters of precision. These pharmacists, they triple check every dose. They spot drug interactions in their sleep. If your notes are like color coded, the mid-rate game is unmatched. They're on top of it. Their motto is measure twice, dispense once. All right, so that's the first
I
one.
like it.
The next one is Synthra. These are the creators, innovators and problem solvers, compounding wizards, research junkies, and the ones who ask, but what if we tried this instead? Ideal for those who dream of opening their own practice or discovering the next blockbuster drug. Their motto is formulate the future. The third house is the house of botanics. These are the natural healers. They're passionate about holistic care and geriatrics. These pharmacists know their herbals, they counsel with heart, and they see the whole patient. Often found in ambulatory care or MTM, advocating for one med to be de-prescribed at a time. Their motto is healing begins with listening.
Okay, so those are the stoners.
And the final house is Statica, the fast reacting ones. ICU, ED, Code Blue, they thrive in high stress situations. They don't blink twice. When there's TPA on deck, these adrenaline-fueled pharmacists were born for hospital rounds, rapid response teams, and no crash cart drawers, numbers by heart. They know, they're like, okay, drawer number 16, this side of the hospital. Their motto is always on call, always ready. All right.
Here we go.
So before we help Hila select her house, Sam, which house do you think you relate the most to?
Well, I have to immediately lean towards the Synthra with the compounding wizards. Doing the sterile compounding and compounding in general. Mixing things, doing those potions over there. So that would be the initial guess. Then Maybe statica a little bit. Just let's just get this over with. Let's just go. Versus trying to have everything planned and timed out. But I'll go with being one of the creators.
Love that
Synthra.
for you. Love that. And Robbie.
You know, it's so funny. I was going to say the complete opposite of Sam over there. Initially, I was like, oh, botanics, that's me, you know? And then Sam was like, oh, that's the stoners. And I'm like, oh, I don't know how I feel about this one anymore.
Hey, you're from California.
Yeah.
Those Cali kids.
Yes, I am. But just because, you know, it's a cure personalis, right? Cure for the whole person. It's more than medicine. It's more than make it like doses and deprescribing. It's how they doing like in total, right? And then I think everybody has a little bit of capsula in them, honestly. You know,
Okay.
we're pharmacists. We're obsessed with doses, accuracy. So yeah, I gotta say, opposite of Sam over there.
So that's exactly what I expected from you guys. And it's perfect. And then me, I am definitely for sure statica. Love that fast-paced environment, high-stress situations. I'm a little ADHD light, so I need stuff to keep me occupied and keep me from being bored. Now we can see which group, which house Hila will be in. And you guys can also answer the questions as well to see if you really belong in the house that you think you would be in, okay?
Okay, let's do it.
I'm ready.
So the first question is, when you study or work, you prefer to A, organize every detail perfectly, no loose ends. B, experiment and brainstorm new ways to solve problems. C, connect with patients and focus on their overall wellness. Or D, work fast, stay sharp, and act quickly in emergencies.
I can only pick one.
Yes,
Only one.
you
I
got-
mean, you can rank them a little bit, but
You know
we
what?
got to know your what's calling to you.
I really like patient interaction. Like I have a problem as a student right now where, because I'm a student, I have the time to talk to patients, so I will talk to them a lot. So I'm kind of leaning towards C, where it's like really getting to know the patients and connecting with them. And I it's always at the back of my mind. I'm like, when I'm a pharmacist, I'm not gonna have the time to do this. But I also like B, about like, I think I'm definitely a bit of like a creative problem. Like I like creative, like new ways to approach problems. I definitely think like that. For example, I really wanted therapy dogs to come to our school. So my solution was to join the mental health club at the pharmacy. I became the president, and I was like, we're bringing therapy dogs to pharmacy students.
There you go.
And was it successful? We're still work
It
in
was
progress.
successful. Yes, we brought the dogs and people loved it.
Hey, awesome.
So I'm always like, I like that. I like, so I think B and C. So
Okay.
it's hard. I don't know which one I would rank first, but maybe B first and then C if I have time.
Okay, B first, and then a little bit of C.
Yeah.
Got it. All right. Next question. Your ideal pharmacy job is A, clinical pharmacist with a reputation for flawless accuracy. B, compounding specialist or clinical researcher pushing boundaries. C, ambulatory care pharmacist with a heart for patient counseling. Or D, critical care pharmacist on the front lines of the ER.
This one's hard.
You
I
don't know-
like A because I wanna be like a reliable.
You're that badass.
Yeah, like
Yeah.
I want, you asked me about the spectrum of an antibiotic and I got you. I don't even need to pull out my antibiotic.
It's in your brain. Love it.
Yeah, but I know myself. I'm also, I think C, right? The patient interaction, I just know it, but I want to be A. That's my goal. So I'm going to say C is just part of who I am.
Okay. I'm keeping track here.
It's hard. I don't know. The hat's going to be confused. I'm Harry
I
Potter.
know, right? It's like swirling. It's like,
But ultimately, Harry got to pick, so don't forget that.
That's a very good point. That's true.
Moving on to question 3. Your go-to phrase is A, double check, triple check. B, there's always a better way. C, listen first, then treat. Or D, code blue, let's move.
Maybe listen first, then treat.
I think that's yours as
Maybe.
well.
I think so.
Xavier's like, I already got this one pegged.
We're starting to figure it out. All right, 2 more questions, and we'll have your house selected.
Oh, great.
Okay. Number 4, what's your coffee order? A, black with no distractions. B, latte with some wild flavor, think matcha or turmeric. C, herbal tea, please. Or D, triple espresso, no time to waste.
B. Latte.
Got a nice little latte going.
Lattes are great.
And finally, the last question.
Right.
How do you handle stress? A, planning and prepping like a boss. B, channel it into creativity and problem solving. C, take a deep breath and talk it out with someone. Or D, focus and get things done fast.
D.
Ooh, we got a D in there.
You'd be surprised. I actually like
Interesting.
stress. I'm a little bit of I need a little bit of stress to.
Oh, so she like that stress-induced focus and get stuff
A
done.
little
Just a little bit of stress, and then like, all right, I got to get this done by this time. Be efficient because I don't have this much time. All right, so now we're gonna put you in your house. Are you ready? Get a drum roll, please. You are mostly house botanics, but a little bit of center.
I had a feeling. Because at first Synthra I was like, am I Synthra? But then I was like, maybe.
Yes. So nice. That's a good combo. A lot of us resonate with multiple houses, but that's a good combo of houses to have for sure.
Okay,
You look
great.
like Robbie, I think. So same realm of pharmacists.
Just gotta talk it out.
Can I use that in my job interview in the future?
I mean, they have to listen to the podcast
Yeah.
first so they can
Yeah, I'll be
understand.
like, can you
Yeah.
first please listen to this, and then that'll help you decide if I'm fit for the role.
Yeah, add it to your CV. That's how you brag, right?
Synthra and both.
All right. Thank you guys for playing the game with me. Now we'll move on to Sam to do the weekly weigh-in.
All right, thank you, Zay. We've got a weekly weigh-in of someone asking about the first pharmacy job. So I just started my first pharmacist job, and no one warned me that patient counseling would feel like public speaking while defusing a bomb. Half the time, I'm sweating through my coat, trying to remember the key points without sounding like a robot. The other half, I'm just trying to get patients to care at all, especially when they're speed walking away, while I say possible side effects include. Also, why does it feel like I'm improvising every single counseling session? Does the panic ever stop? And is it normal to black out halfway through counseling and just hope you covered the important stuff? Hila, you seem to resonate with that. What's that first thought I'm feeling?
Definitely been there. Especially, I think, as a first year student, when I did my first placement, you're really like, oh my gosh, I got to recall on the spot. I don't have my notebook. I don't have my, the computer's not always accessible to look things up. And we're wearing our white coat as a first year student, so they think you're the pharmacist.
You're a doctor. You're good to go.
And you're just looking at them like, let me get the pharmacist. And they're like, aren't you the No, I'm a student.
Not yet.
I'm
not
just
yet.
a baby. I don't know.
All right. Any of those appies, Hila? Did you have a kind of that deer in the headlights moment, patient counseling? And do you remember the details, the drug, or what that curveball was? Does anything come to mind for you there?
I have one that I don't think I'll ever forget. First year. So in first year, it was more still like pharmacology. We learned the basic OTC medications and just some general. We didn't know too much about different disease states yet. Like we hadn't even learned diabetes yet until second year. So my pharmacist, it was my first year. The pharmacist, he gave me a basket and he was like, go counsel this patient on this medication. I was like, okay. I just looked at it and it was a jug of hydrocortisone cream and another jug of hydrocortisone ointment. And it was like the full jug that we usually like scoop out and put into the little container. And so I'm standing there as a first year student. I'm like, okay, I know this is a cream. It's a steroid. Okay, I know what steroids do. They're anti-inflammatory. It's probably for a rash. I know that. The SIG says apply to affected area. That's not telling me much. And also, usually we give patients a small amount, like 30 grams.
Sure.
Why am I giving them the whole jug? And also, why am I giving them a cream and an ointment? What's the difference?
I'd be asking the same questions too.
I don't know. My pharmacist, I don't think he recognized, like he kind of just gave, I think I was like, okay, he's expecting me to know this. And I do know this. It's a steroid cream. And I'm like, maybe the patient can help me a little bit. So I walk up to her and I started by saying, okay, do you know, is this medication for you? And she goes, no, it's for my mom. Okay, do you know what she's using it for? And she looks at me, she's like, yeah, I know what she's using it for.
Like,
And I'm
dot,
just
dot, dot.
And I actually froze. I grabbed it. I was like, well, it says to apply to the affected area, but there's a cream and an ointment. And I'm like, what area? Why am I giving both? Why so much? I just froze. And the pharmacist fully realized, and he just stepped. He was like, okay. And he's like, okay, ma'am, like this one, you apply to like the folds and this and the other one. Like, and I was just like, listening to him, I'm like, wow, I never thought a steroid cream would catch me so off guard. Yeah, that one really resonates. That story really resonates with that experience in my first year.
Yeah, I can see that. Just not getting freezing right there. The deer in the headlights, indeed. Xavier, anything that came to mind for you?
Not for me, but I did have a student once, and he was counseling on levofloxacin, and that one has some pretty gnarly side effects. And he was trying to counsel a patient, and he was telling them about the tendon rupture and all these other things, and the patient was sitting there like, no, no, I don't want this. I don't want this antibiotic. He told them about all the severe side effects. So I had to like step in and explain, oh, this is a rare side effect, but we tell you about it because we want you to know and that it's a risk that it can happen. But he was like, no, I don't. Can you call the doctor and tell him give me a different medication? He was like, yeah, I'm not taking that one. I think I had this one before. I didn't like it. So we end up calling the ER doctor to get it switched to a different medication, a different antibiotic. But yeah, that patient was not having it after he heard all those side effects. He was like, no, what else? Death? No, it's like,
No.
no, it's okay.
Okay. Robbie?
The one comment that got me feeling the deer in the headlights, this was pretty recently actually, and it wasn't that it was the question and the way they asked the question that I was just like, and I just, laughed my ass off. But I was counseling on rifampin because this person had latent TB, and I go, what questions can I answer for you? And he goes, the classic, oh, can I drink on this medicine? And I tried to explain, I was like, this is pretty tough on the liver. I wouldn't recommend drinking on it. He's like, what about a little bit? I'm like, I can't in good confidence tell you should drink on that. You should drink while taking this medicine. He goes, and he was also European, so maybe it was like the European accent, but he's like, but what if I want to get fucked up? And I'm just like, I just sat there, I was just like, I just told you can't be drinking on this, man. Like, I can't in good confidence tell you any safe amount you should be drinking at all. And finally I'm just like, hey, you're going to be the one in charge of your medicine. I can't tell you what to do after you leave. I can give you the information, and it's on you to follow that or not. Okay. I'm not going to hold your hand through it. So if you drink, that's on you, but I'm telling you, that is not in your best interest to be drinking on this medicine. And he's just like, okay, bye. I'm just like, okay. But that's when I was caught deer in the headlight. I was just like, cause I was just like baffled, and I just started laughing. And I realized, should I be laughing at this comment? I don't know. Like, is he being serious or is he messing with me? And so, yeah. Anyways,
Oh, sorry, I couldn't stop
Hope he's
laughing.
doing okay.
That was so
went
funny.
and got fucked up, apparently.
Yeah,
Having a good time.
probably.
I
I was like, that guy was serious, man. These Europeans, they they like their drinking, right?
I would have been like, you can do what you want, but I don't recommend it.
Yeah.
How about patients like that don't want the counseling or just walking away, don't want to hear it? Hila, any happy experience of that where they just don't want to talk to you at all?
I mean, I've seen a lot of patients who are in a rush, but I kind of navigate it as if I know I have to counsel, it's a new medication. We have to like scan the medication for them to pay, or even if there's no fee, we still have to scan it through. So I don't scan it yet. I first grab the medication, I have the bottle, I'm like, okay, here, this is how you take it. Here are the side effects. And then I scan it after. So they have no choice.
Force them to do
If they
it.
want it, they have to listen to me first before I scan it and give it to them.
Good technique.
Yeah, that's my technique.
It would work. Robbie, you do any of that when you were at community?
I get a lot of people who don't want counseling now working in a psychiatric hospital. You know, you stabilize them and then you try to offer some discharge counseling, but some of them just don't want to have it. They're like, no, I don't care. I'm not taking this when I leave. I took the meds while I'm here, but you can't make me take anything. And I was like, oh, okay. Well, you're right. I can't make you take anything. And I just leave it at that. It's, you try your best to offer counseling, but you're not going to you can't make them do anything afterwards, unless they're reaced. But if we're discharging them, they're not reached.
Zay, any techniques that you had either in school or afterwards?
When they don't want counseling, I'm usually pretty happy.
All right, peace.
I'm like, hey, if you don't want it, the instructions on the bottle. I usually do a
Just
detailed note.
Denied, and
we-
good to go.
We usually write up the discharge note for the doctors, and I usually put a lot of detail in my note. Like, okay, start this one on this day. It's a 10-day partial supply. You have more coming in the mail. I write those little tidbits on my note, so they read my note. They can get most of the information outside of the side effects, and then the instructions are on the bottle. But most of the time, I'm just kind of reiterating side effects or how to take something a certain way. But yeah, if they want counseling, sometimes they throw the medication back at you. I don't want this. I told the doctor this doesn't work. So I get all types of patients. So you just got to go in with an open mind. I usually just try to stay positive. Let the patient know that they're always right, even when they're
Always
wrong.
right.
And that tends to it works pretty well for me. So just the other day, I had a patient. He was taking all of his inhalers incorrectly. He had not incorrectly, he was using them too often. So he had 3 inhalers. He had a Dulera inhaler. He had a tiotropium inhaler. So he was on all 3 classes of inhalers. And then he had his rescue inhaler, which was a Combivent inhaler, right? But he was taking all of them 2 puffs 3 times a day. He was like, this is how I've been doing it for years. My lungs were at like 20%, and now they're up to 60%. My doctor said it's okay. I've been doing this forever. So what I did was I went in a room to kind of like let him know, like, hey, the nurse has to scan each time you give the medication. If you're taking it more than that, it's not allowed. We have to like lock the medication up to make sure you don't take it more than what's prescribed in the hospital, right? But basically, he sat there and talked to me and basically gave me his whole life story, like his whole military history since, I don't know, I think he was in Vietnam War. Yeah, so I got the whole history from A to Z. I was in there about an hour.
Doing some
Luckily, I didn't
botanics.
have too many patients, but basically I got on his good side. And then I went back and caught up on my work, and I came back to him like, hey, I want to just, we talked about how you want your medications, but I want to go over a couple things with you. So it's like, well, the reason you can't take this medication here is because, these have the same drug in it. So it's a duplication of therapy. So you're going to have more side effects. So this one, you only need to take as needed, and we'll give, the tiotropium daily. So he was doing it 3 times a day. But this one, it's a long-acting medication. You only need to take it once a day. So once I explained that to him, I was like, oh, okay, I'll take that one once a day. And then this one, it doesn't need to be 3 times, only twice a day. Okay, I'll do that. And this one only if you need it. Okay. All right, let's do it. Thank you. Hey, you the man.
I think he played you. But what if he's sitting there correcting you? They're like, no, that's not how it's done.
And be like,
So
sir, I went to school for 8+ years, did how many residencies, how many board certifications, and have been here for how long?
And you're still wrong.
Hila, have you been corrected by patients before in appies? Realized you said something wrong or ended up recovering from whatever that counseling was going on when you're sweating through your white coat?
No, not corrected, but I think I've actually learned a lot from patients, or they'll refresh things that I've learned in school. So I guess one time I went to counsel a patient on, I think it was perindopril, and she was quite young. So I just assumed maybe, her blood pressure is a little high. And, I said, I went up and the mistake I made was I guess I assumed. I was like, okay, like, is this for your blood pressure? And she corrected me and she was like, no, actually, I have like early onset chronic kidney disease. And I remembered in that moment, I was like, that's right. You can use perindopril for a CKD. And then I kind of like navigated the conversation differently. But I think that was a moment where I was like, we forget that a lot of these medications, I'm so used to my older population patients, it's all for their blood pressure. So, I just didn't even think that like a younger patient might have like a kidney condition. So that was kind of like a good learning moment, I guess I would say. That's how I try to take things. And just as Xavier's earlier story, I know we come across, especially now, with like a lot of patients who are like maybe medication hesitant or vaccine hesitant. And I don't know if you guys have this in the States, but in Ontario, we have something called medication reviews, where once a year we go over patients' medications with them. And I called a patient because he had requested a refill. And I just, I was like, hey, like, would you want to go over your medications with him? He was super against, meds and doctors. Sometimes all it takes is, you're right, a conversation. Like, I just kind of was like, listen, I know there's so much information online to the point where even I'm questioning things. I'm going to school and I'm questioning things. The other day, I saw they're selling GLP-1 patches for weight loss. Make it make sense. I don't know. But, there's so much online but just talk and kind of like validating them about, yes, there's so much information. It's overwhelming, but you need someone that you can trust. We care about your health. And I just talked to him, and the next day he called me back and he said, because of you, first time in, I think, 4 years, I went and I got a blood test done to go to my doctor.
Oh,
Good
very
job.
nice.
He came
Wow.
to the pharmacy, and I just remember that moment. I was just it felt so fulfilling. It took took some time to talk, but I thought it was so worth it. So I
Hmm.
think sometimes you're surprised. Patients might come up as defensive at first, but if there's hesitancy, sometimes if you just connect with them, I find you really can. You can change their mind, or if you go in without the changing their mind, but you're there to hear them out and kind of like open some new perspectives, and you're engaging with them. I find people are more open than you might expect. Yeah.
So did you get yourself a latte after that victory?
I should have, but I'm not getting paid right now, so we can't afford
Okay,
$7.
no lattes. Okay, but you wanted one mentally. You were like, yes.
Yes. Yes. I may have gone and got a chocolate bar.
There you go.
It's the one bad thing of working in a pharmacy, by the way. You constantly have access to.
Junk food.
Robbie, any stories come to mind for you?
Yeah, not a patient, but actually a student who corrected me once and wasn't mad about it. I know some preceptors kind of, get their panties all bunched up when they get corrected by a student, but, I was happy they corrected me. But we were reviewing a patient's medication list, and one of them was Lamictal. And I had asked, like, okay, do you know how many days they could stop therapy before having to restart Lamictal? And, and then I was like, it's 2. And he's like, I thought it was 5. I was like, no, I think it's 2. And then we looked it up. It was 5. And so clozapine is 2. And that's why I was thinking it was 2 days.
Yeah,
But
I was paying
yeah, it was
48
5.
hours.
So I was like, oh, I'm glad I know that now because, like I've been thinking about that wrong. And, whenever I verify a prescription, I'm thinking, oh, has it been 2 days? And I'm like, but now it's like 5 days. That's a little better. I don't have to be so up in arms about it. Like we have a little bit of grace here. So, a little bit of room for some non-adherence, and which is very much needed in a psychiatric hospital. I'll say that. But yeah, I learned something new, and I'm glad I did. So now I pass on the correct information. So, but of course, the student presented in a way that was like, "Oh, I thought it was this." It wasn't like you're wrong. It's all about how you present the information, right? So, yeah, glad they corrected me.
There was one, I think it was a nurse who's, older, been a nurse for many, many years, but they were upset about their syringe and essentially the hub of an oral syringe, and the line, starts at the end of the hub or the beginning of the syringe itself, and there's that, gap of liquid and stuff in there, and they were adamant that they were misdosing or syringes were inaccurate for their, I think it was their cat or something that they were doing for a pet. And so I was coming out and explaining to them, it's like, no, the line starts at the end of that hub. You can see it there, like they mark it for you, and then you're drawing it down to whatever the dose was, 0.5 ml or something. And it's like, yeah, you're every time you do it, there's gonna be that little bit of that liquid there on needles and stuff. And then she just started going off. It's like, no, there's not. Like, I've been a nurse for 30 years and there's not a little bit of liquid left in the hub and needle on this thing. And it's like, my friends or something like that. And in my head, I wanted to be like, well, you're going to blow your friend's mind when you go tell him this about how a needle works on this thing. But, so it's just pretty much trying to be like, I promise you, draw it up to the 0.5, push the med, it's accurate. This is what it's calibrated to do this. And so I think eventually she, was walked off, and it's like, okay, whatever, but was just adamant that no, this is wrong. And then also, when I brought up the example, her being a nurse, it's like, okay, yeah, it's just a needle that you have on there. There's a little bit of extra liquid in there in the hub and that. And it was just like, no, there's not. That's not how a needle works. So it's like, oh, well, okay.
What do I know?
She always thought it
My
wrong.
bad. Huh? But yeah, that's what made me think of that, of getting corrected there. Any other thoughts on a first job? Recommendations to Hila on her first job counseling?
Maybe I can ask you guys a question.
Okay,
Go for it.
I think we have such limited time, especially, I guess, community or even in hospital. How do you guys make sure you document certain counseling that you did with a patient accurately to protect yourselves as pharmacists? If legally speaking, or how do you make sure you document in a way that you make sure you've covered yourself? And yeah, what tips do you have for future oncoming pharmacists?
And at first, you think you want to be very detailed, but you have to be careful, because if you're too detailed, that's when you can start being nitpicked about, oh, you didn't say this, you didn't say that. So you have to phrase your notes in such a way where you're basically saying, I educated, but don't be too specific, because it's the specific things that are going to get you in trouble if something is omitted. So I'll just say, went over side effects with patient and talked about adherence, how to get refills, etc. But I'm never just stated what an overdose looks like and what to look for before giving Narcan, things like that, because then someone could go back and say, oh, but you didn't say this, so now I'm going to sue you because this person got hurt because you didn't say it. So you want to be detailed, but not too detailed.
Yes, I would agree on that for sure. We have a lot of built-in notes. Some places you work at may have built-in notes to write after your counseling, and they'll have certain things, boxes to check to say, oh, I talked about this indication, this, what to do if you miss a dose. You'll have there, you can kind of check the boxes that you did complete. But definitely, like Robbie said, document what you did. Sometimes you even put who you spoke with. I spoke with Dr. such and such. He was aware that that I notified him that the patient hemoglobin had dropped by 2 points, so I was worried for bleeding. But he said, patient got a lot of fluid, so he wasn't too worried about it. So basically, I would just say, discuss with doctor about dropping hemoglobin. Provider is okay to continue medication at this time. So simple like that. Keep it general. And just cover your bases and make sure you're doing what you need to do to complete everything. Especially if something where it's gray area and you don't feel comfortable about it, definitely confirm it with the doctor that is what they want for sure. And then confirm what you didn't like about it. Oh, these are certain things I didn't really think were okay, but I discussed with the doctor. He had a patient-doctor discussion. They were okay with the risk. Boom. So, boom, you're cleared because you checked with the doctor checked with the patient. Everybody was on the same page. Yes, it's risky, but they still wanted it. Boom, just like that.
So pass on the blame to someone else, Xavier
That's
saying.
right.
Just cover your bases.
Yeah, I would say documenting, not, as they're kind of saying, not worried about being too specific. Just, your general things of, yes, you did counseling, or, spoke to this person's, write people's names, who you actually spoke to, not just clinic, but hey, it was this person that authorized this or changed this. I think it's also part of it is a bit of a feel of like knowing it's like, oh, this is something specific, or this patient is being a little difficult. Let me be a little more specific on, hey, I did tell them this, or specific drugs are concerning. I think it's rather different with compounding. Obviously, there can be a lot more unique situations and probably a lot more liability on specific things. But there was like didn't happen to do with our pharmacy, but it was, I think, in the state of Oregon, of a ketamine nasal spray that essentially someone was using and ended up getting very sedated and like crashed their car, and pretty much sued that pharmacy that they weren't, didn't counsel them about it could affect their driving and things like that. And so specific things like that, where it's like, okay, this could be a specific sensitive area. We need to make sure at least you're documenting or saying, hey, yeah, this can affect you. It's like, it is written in the documentation. It's in the paperwork that they're getting. But you start to find out a lot of people don't read any of that. They just throw everything out. And it's like, yeah, it said this on like 6 different things. It says it on your paperwork. It says it on your label. It says it on this. It's like, oh, yeah, the label came off. I threw the paperwork out. I don't read anything. I just do whatever. So, having that documentation, there can be specific things you're doing, but in most parts, it's not too worrisome on having every single thing, making sure you're written down there.
I think that's one thing they tell us a lot is document, document, document. So thank you for the tips on kind of like how to make sure we cover our bases.
All right. Well, we got, I think Robbie's got another story for us from somewhere that you can take it away.
Thank you very much. Okay, so on this segment of Pharmacy Pandemonium, this story is written from a person named Slap a Label. Don't just slap a label, but that's their name, Slap a Label, from Reddit. And this some context. The question was asked about bad preceptors and their experiences. So, Hila, I'm sure you're going to have a lot to say about this one. Okay. The first day, she took me into her office, proclaimed I was only there because she was, end quote, doing the college a favor. She didn't give me any work to do, just left me sitting there, so I started reviewing guidelines. I always showed up 10 to 15 minutes early, and I guess she was annoyed about it. She finally yelled at me, yes, yelled, and I shouldn't be there to be babysat for 10 minutes or so. It was totally weird. I continued to arrive early, just wait outside of the clinic until 7:59, walk in very slowly down the hall, arrive at her desk promptly at 8. One day she asked me what a particular test did. I didn't know, so I had to go home and research it and bring her the information. I typed out a neat little one-pager guide about what the test was, who it was for, and how to interpret the results, and presented it to her. She threw it in the trash because, in the real world, you won't have time to do this, so it's garbage. Okay. She left on vacation for a week. She told me it was for a final interview during week 3 and left me in charge of interpreting the INRs and changing doses on warfarin while she was gone. She must have accepted the job and put it in her notice because that was the last time I saw her. She clearly hated her job and hated my presence by extension.
Wow.
So, Hila, what's your overall first impression and reaction with this poor student's story here?
I just think that's so unfortunate, especially because I think, and if you've all, I find that students, most of us, we're all just very eager to learn, and we're all really looking forward to our rotations. And I think that's just, especially on the first day, having so bluntly, being told, I basically being told that I'm not excited to be your preceptor. That's That's a tough pill to swallow, no pun intended. Yeah, I think as a student, that would be very disheartening for me to hear, especially if it was at a rotation I was really looking forward to go to. Because for us, this is our first experiences in a lot of different areas in pharmacy. It's how we can dip our feet in the water of different areas of pharmacy, and it's a great way for us to have these experiences. So that would be really heartbreaking.
Yeah, definitely. If you get a bad preceptor, that's something you're not excited about, it can completely change the trajectory of your career. So that is really unfortunate. Have you ever experienced a preceptor like that?
I want to say thankfully not at all.
Good for you.
I
Okay.
I feel I've been very, very lucky. I've had truly, truly wonderful preceptors. They've all been busy. They're all busy, but they all have made time for me. They've all been very open to answering questions. I find that's the most important thing. I As a student, I find being comfortable to ask questions, appropriate questions, that's for sure, not just everything. But feeling comfortable enough to ask your preceptor questions, ask for guidance, or even if you're being challenged by your preceptor, if your preceptor's putting you on the spot, feeling comfortable as a student to say, I'm sorry, I don't recall it. Can you give me a moment to look it up and I'll get back to you? Just having that comfort of recognizing that we're still learning and we're still actively recalling a lot of the things that we've been taught. A lot of the stuff that we've been taught, is one lecture we learned maybe in first year or second year, and we haven't seen it since. It's the first time we see it again in real life, in practice, and we need a bit of a refresher. So just having a preceptor who's open and allows us to kind of go back and forth with them, but also allows us a little bit of independence too, like gives us things to do independently. It feels like we're growing as well throughout our rotation. I find that that's the most helpful, at least for me as a student, that's been the most helpful way of learning for me personally. Yeah.
Yeah, definitely. You have to sort of practice the information in order to really solidify it, right? Otherwise, it's just memorizing and sits in the brain and goes away.
You write it on the exam, it's gone.
Exactly. Xavier, what about you? What's your initial gut reaction with this story? What are you thinking?
I think that's a terrible preceptor. She shouldn't have taken, or he or she. Sorry, I don't know if it was a she.
She.
It was
Says
she?
she.
Okay, okay,
Yeah.
she. I didn't want to just assume it was a she. But she, some people assume. I'm like, I don't never want to assume.
Hila,
But
speak up. Say something right now.
but she shouldn't have accepted that student from the university if she really just knew she did not want to do it or she didn't have the time to actually do it. So I think it's very inappropriate of her to do that, one. And then two, just the way she handled the student was terrible and then just left them hanging. Like, no matter how much you hate your job or how much you don't like precepting students that much, if you're forced to do it, it doesn't matter about any of that. You still should treat the person with respect, and she didn't do that at all. So
Have you ever
I don't
had a
like that.
preceptor like this?
No, all my preceptors have been fantastic. I mean, sometimes you may have one that doesn't fit like your personality or something, so you might not necessarily. You have to figure out the dynamic between you as a student and that preceptor. But I don't think I've had any terrible preceptors for sure.
Also lucky. How about you,
Yes.
Sam? What's your gut reaction?
I mean, it sucks. You're, as we're saying, you're going in excited. You want to learn, still trying to learn, do everything, have a lot of, fun and improve on everything you're doing, and then just getting shut down or just demoralized from that. It's got to suck. I think thinking through is like, oh man, am I wasting my time? Like, probably one of the things would be like, am I going to get failed now? Like, they just don't care. They're just going to be like some stupid thing. And like, okay, yeah, this person fails or doesn't no pass on something. And then you got to redo something because your preceptor is just hating life at the moment. Hopefully not life in general, just at the moment. Whatever's going on, it's just short term.
Have you ever had a
But yeah, that'd be
preceptor like
rough.
that?
I mean, not really. I mean, I'd say there's, again, a range. I think it's really more of kind of the structure. So you got preceptors that you're really more doing projects and not really kind of with them, or still, they're still spending time and checking in with you versus, some of the ones that we had at hospital where, there are professors and so literally their job is having preceptor, students there. And so they're able to engage with us a lot. And, you're able to learn a lot through those. So that structure is designed for us and to help us learn, and they have the time. And kind of as Hila says, you're busy, and if it's not set up that way or doing that thing, I'm sure a lot of community is like that as well, where you're just in there counseling, doing whatever to keep numbers up, and it's more of just an extra body in there. Where I don't know how lucky we were, if it was or wasn't, but we had a lot of professors that were also our preceptors in hospital and stuff that were able to dedicate a lot of time to us while we were on our rotations.
Well, I was not so lucky. My very first introductory IPI, it was just, that basic one where you're going for 4 hours just to see it and go. And I remember I got there and the preceptor was very proud of where she went to school. And it was the other school in Omaha. We were at Creighton, then the Nebraska Med Center, and she went there. And she was very proud of it. And it's a great school. It's something to definitely be proud of. But I could tell she just did not like Creighton students. And she even said at one point, she's like, yeah, I like taking Nebraska med students. I went to school there, but since I hear they make me take Creighton students, so I have to take. I'm showing you around today, and I'm just sitting here. I'm like, what the, dude? Like, I've never been in a hospital before. All I knew was community, and this is how we're starting off. I was just like, okay, and so that whole 4 hours, I just shut down. Didn't want to say anything and talk to her because I already got the impression she hated Creighton students. So I was just like, okay, whatever. Luckily, they did not change my position where I'm at now. I'm at a hospital. So, yeah, but you're very impressionable as a student. So be nice. Be nice to your students. Anyways, I'm still upset about it, clearly.
I haven't let it go yet.
Okay, you're always upset.
I'm always upset. I know. It's an upsetting world, okay?
Very.
So, Hila, when does a one-page resource become garbage in the real world? Have you ever had a preceptor contradict teaching like this?
You know what? I actually, okay, to be clear, you don't tear up someone's work and throw it in the garbage. That's very unprofessional.
Yeah.
Not a good example to set. But actually, this is kind of funny because in school, as students, we're so worried about getting our marks, right? So when we have, for example, when we get a patient case and we have to do a workup, we have maybe a couple days. I think the shortest time I've ever been given is maybe 1 day. But most of the times we have a couple of days to prepare and do this workup. So we look at all the guidelines, we write essays and paragraphs doing this one patient workup about, this one, it's the patient that, yes, they have other health conditions, but everything else is perfect. And in this scenario, it's just this one organ that's failing and we just got to find it's a school scenario. It's very hypothetical. It's not real or applicable. First hospital placement, it was I did one in general medicine unit and one in the cardiology unit. And my pharmacist, this was in the cardiology unit, she wanted me to do a workup on a patient. She actually gave me the whole day to work up this patient. So I spent the whole day, I wrote an essay on therapeutic alternatives for endocarditis and and I wrote an essay. And at school, usually our monitoring parameters is like a tiny section. We just write the side effects of the drugs and that's it. So I present this to her at the end of the day. This was in second year. She's reading it and she looks at me. She's like, "This is great, but a doctor won't have the time to read all of this, and you yourself won't have the time to write about all this. And also, why is your monitoring parameters so small? Like, how are you going to monitor the patient? And she kind of made me realize that what we're learned in school as students, we're kind of surviving in school a little bit, right? It's not practical. It's not real life. And it kind of made me take a step back and realize I had the whole day to work up this one patient. My pharmacist I think she had like 30 patients on her floor, on her roster, that she's monitoring all of them. She's following up. She has new patients. She's discharging patients, right? So I realized this was not realistic. And we're not really taught this in school either. It's a skill you gain working. And it was the first time I realized I can't do workups the way I've been doing them at school. At school, you're doing them for marks. It's about clinically, are you accurate? Did you get the first line drug? Did you pick the right drug? Did you catch the DTP? That's what we're doing at school. In real life, it's also efficiency and time and getting to the point. And that, so again, this scenario, very extreme. But I do think as students, we do need that guidance a little bit about the real life application, how it is different from school. And it's you will only learn it, I feel like, on the job or with great preceptors that help you. After that, she really walked me through it and helped guide me in how I can be more efficient and do workups in a more like realistic way. So I had guidance. This student unfortunately didn't.
No, they did not. Yeah, it sounds like you have a great preceptor who's showing you how to actually apply the information in a very practical way. That's great.
Mhm.
How about you, Sam? Have you like any experience, your work getting wasted, these one pagers?
I would say, I mean, them being kind of wasted is if it is just kind of fluff, or you're asking for something specific, or how to do this. Like, if we're trying to be on the extreme side, whatever that test was that they were doing, probably could have been in a paragraph of, here's the test, kind of as Hila was saying, here's your test, here's what you're looking for, main things. And so being more exact as what you're kind of talking about, of time and just getting through that. Yeah, having a whole bunch of pages, or you think of it like sticky notes or little notes that are all over the place. Yeah, you have so many that they're no longer useful, and it being your few little notes of, hey, I need to make sure I remember to do this, this, and this, or whenever something happens or we're working on something, it's these couple things, and they just keep building up and more, and then yeah, it's kind of gets pointless of reminding yourself these little details. So trying to keep it simple, short and simple. What to remind. Sometimes you do need those longer things, but I can't really remember a preceptor like backing off on that or switching something like that. Maybe where it wasn't relevant. So I remember doing something where it was more like a research thing that I was doing for a company and looking into something for them, and pretty much my paper, I can't remember, it was like 3 or 4 pages of writing about whatever it was, and my conclusion was pretty much like, this doesn't apply to your company and not really needed. So I mean, they still took it and read it and everything, but it's like, yeah, this was kind of a waste. But I don't think they really knew that at the time of like when they had me look into it.
And how about you, Xavier?
Well, we don't. For our students at the VA, I do precept a lot of students. They do a one pager for their new drug. When they just kind of, new drug came out, we have them do like a one pager, maybe front and back. What's this new drug? What studies, how did it get approved? What studies show that it's significant? And then how would it apply at our hospital? Would it be something we could use? So we do one pagers for certain instances, but yeah, definitely like Hila said, with patient workup, I do go over with all the students like how I would like a soap note presented, the information that you need to be collecting. And I understand that over time, it may take you a while to collect all the information, but then eventually you'll be able to narrow it down, be more concise and efficient with the information, and pick and pull exactly what you need and present only the relevant information. Because my hospital, I am a acute care pharmacist, so we're mostly focusing on the acute issues, and then we're aware of the chronic issues and how they play into the acute issues. But the major focus for presentations, because we have so many patients we have to get through. Like if we just went through a full soap for every single patient, we'll be there for hours. And I have 3 patients to discharge, doctors to respond to, notes to write. So I can't sit there for 2, 3 hours just going through full soap notes with you. So I'm just basically show them how to be efficient with their presentations, and that'll help them as they go along with the rotation. They slowly improve and can take on more patients.
Yeah, well said. Last question for the sake of time, Hila. What advice would you give preceptors to help make the rotation meaningful for students?
That's a really good question. I think Just from my own experience, what I've found is the most useful is when, well, one, on day one, you can just sit and talk to your student. I think we as students know that preceptors have different teaching styles. So you can go over your teaching style. I actually had a preceptor who did that with me, but they also asked me, what's your learning style? Like, do you prefer doing readings or do you like doing like things on the spot? Kind of like we kind of went over it. And just please be open to questions. I find I've had a few friends tell me, they've had preceptors that, if they say, don't ask me a question unless you look it up first, or like more like just don't find out the
No.
answer yourself. Yeah. So I just find that really does shut you down from feeling comfortable of like, is this an okay space for me to learn? Because we learn by asking questions. That's how I learn. I think as students, we can definitely do a good job of like making sure we ask good questions, but creating an environment where questions are welcome and that it's accepted when a student might not know something. So we're guided and we're encouraged to go and find out. And we come and we're given maybe a little bit of guidance and maybe specifically what you're looking for, or it could just be a just a random because we get quizzed all the time. So, but us feeling like, okay, even if we don't know something, that's okay. Because honestly, I find as pharmacists, I'm learning there's a lot we don't know. It's how you navigate around it, we're experts at finding the information, right? So teach your students that. Teach us where we can look things up, or give us the opportunity to look things up and get back to you and give us more guidance, or, correct us, but I just find work with us. That's in my opinion the best way to learn. And yeah, don't make it just about how smart are you on the spot of recalling we're still learning, and this is the prime time for us to really learn and apply what we've learned in school, because I do think I learned the most working. So, and we're always looking forward to your advice, your tidbits, your life experiences. We're nervous and we're excited. So yeah, I just think be excited with us. I know it's a tough profession, but we're still coming into it with our
They're still cheery.
naivete. So yeah, don't scare us too much.
I'll tell you a secret. If your preceptor ever says, that's a great question, look it up and let me know what you find, 9 out of 10 times it's because they don't know the answer. Don't ever take it personally.
Yeah, that's fine. It's a good trick.
You'll use it, trust me, when you're done. Sam, what advice would you give preceptors to help make a meaningful rotation?
I would say kind of similar. I think maybe we're fixed on wanting that botanics preceptor that they like to listen. I would say having some sort of structure. So one of the harder ones is like they're just, here's a project, or just go do this or that, and like not really knowing, especially being a student, like, you don't know that much. So helping them with having some sort of structure on kind of what you're doing. And then I would say asking ahead of time kind of what the goals are for your time there, and be opening to try to fulfill those. I remember one time asking towards the end of my rotations that I didn't have any sort of management rotations. And so I asked him, he was at a hospital, hey, I don't have this, maybe if I could, talk or be a part of any sort of management discussion or what things. And they weren't really part of that, and, kind of chuckled about it, but it ended up getting me into one of the manager meetings that we went to. So I got to sit in on, a few meetings that they had. So she was willing to try to fit that in, even though it, might have not been part of what my rotation was about or specific things, but it's what I asked her, or something that I felt I was missing a little bit. And it was towards the end of my year, and she was able to help look into that for me.
She helped you explore your interests. That's great. Xavier, advice, preceptors.
So when I precept, I'm a floater, so I'm not always with the same students. I hop around to different medicine teams, and each team may have a different student. So I get to meet a lot of the students and residents as well at our facility. But two things I like to do that may be different from the other preceptors is I like to give praise when they do well and constructive feedback probably more constructive feedback than praise. But those are the two things I really try to focus on, because they need constructive feedback because they don't know that they're doing wrong or what they're doing wrong or how they can get better sometimes without you, pausing and letting them know, like, hey, you did this well, but this didn't do well. So maybe change, this up. So at least, well, like I said, I'm not with them long. I may be with them like a day or two only. So I would get the feedback earlier in the day, like, tell them what I expect at the beginning. We work up a couple patients before they get all the way through with the patients. I'll give them a little bit of feedback. But hey, for the next couple, try doing it this way, or, maybe consider thinking about it like this and work it up like this. And then come back to me in the evening. We'll go through the rest of them. And then from there, I can see if they applied, the information that I gave them at the beginning of the day, if they applied it at the end of the day. I know it's a little bit quicker, but if I'm with them longer, then I can kind of do it later. But definitely give some constructive feedback and let them know what they're doing wrong. And that helps. I find that they tend to learn a little bit faster, a little bit better, or they tend to work harder if they realize they're not doing so well. So they tend to put a little bit more effort into. And then praise. A happy student tends to, enjoy what they're doing. Smiles and, go to the patients and be cheerful with the patients. Like, hey, I'm a student. I'm here to teach you today. They're a little bit less nervous if, they get praise. So, the student did a good counseling with the patient, then I'll come back out and, when they come back to me and tell me what they did, I'll be like, oh, that was a great job. I like how you mentioned this, this, and this, or such a thing like that. And that tends, make them a little bit more cheery and get them ready for their other preceptors who are a lot more intense sometimes. So at least, they get a little positivity to kind of keep working hard when their actual preceptor comes back.
Yeah, praise is important. So what we do at our site is about a couple weeks before, we send a little questionnaire to our student. And the questionnaire consists of things like, what experience do you have? What do you want to work on? How do you best learn? Like things like that, so we can get a feel for what the student is hoping to achieve while on rotation. We're also very clear on what expectations are, because we find that when a student doesn't really know what's expected of them, then they don't perform well. So we try to make sure we are upfront with like what we're hoping to basically get back from the student, and we try to tell them, like, you need to hold us accountable too. Like you're gonna be your colleague. So if there's something you don't like the way I'm doing, you need to tell me so I can fix it. So we try to treat them more like a peer, but with the understanding that they're learning. And going to the praising thing, what I try to do is I try to praise them in front of everybody, but then give a feedback privately, because there's nothing worse than like telling you are wrong to a student in front of everybody. So I think it's all about timing. It's all about timing too, because you're going to shatter confidence or you're going to build it there. Yeah.
Yep.
Well, I think that's it for our pharmacy pandemonium segment. Thanks, guys. I had a lot of insightful comments and discussions and stories. Hila, please take it away.
Thank you so much. This was so great. Very fun conversation. I hope for any students out there who are in their undergrad considering a career in pharmacy, it's definitely a great profession. I do recommend it. If you like chemistry, you like medications, you like healthcare, you like interacting with patients, it's a great field to go to. So I do have a TikTok. It's a small growing TikTok. It's called RX Family with a PH. So check that out. I just like to make little fun posts with my classmates. I put them on the spot. I quiz. And just some fun educational videos here and there. So thank you guys so much. This was such a great and fun conversation.
Yeah, thanks for joining us. Don't forget to like and subscribe to our page, TikTok, Instagram, Facebook at Rated RX Podcast. Send us your questions. Send us your stories. All right, guys, we'll catch you on the next one.
Peace out.
Thanks.